Welcome to another Explain and Describe Learning Explainer, where we take complex medical topics and break them down so they actually make sense. Today, we're tackling one of the most heavily researched and recently flipped areas in intensive care: nutrition for the critically ill patient. Look, if you work in an ICU, what we're about to cover might literally rewire how you handle your very next shift. We are looking at a massive, massive shift in the medical paradigm. For years, there was this universally accepted dogma that we all learned. It went like this: feed early, feed hard, push calories and protein. And honestly, the logic seemed perfectly sound at the time. You have patients fighting for their lives, their bodies are under immense stress, and they're just wasting away. So naturally, the medical community thought, hey, we need to aggressively counter that wasting by pumping them full of calories and protein right from day one. Okay, let's dive into this, because that old assumption, it has been completely overturned by recent clinical data. It turns out that aggressive early feeding wasn't just ineffective, it was actively causing harm. The science has completely moved on. The guidelines for 2022 through 2026 has totally changed, and today, we're going to unpack exactly why. Here is our cognitive roadmap for today. We'll start with the feeding reversal itself, then hit Rule 1, use the gut. From there, we'll look at why we need to go slow with calories and protein, dive into the fascinating world of autophagy, cover refeeding risks, and finally, wrap up with a brand new feeding mantra. Let's get right into it. Section 1. The ICU feeding reversal. Let's ground this in a real-world scenario. Picture a 53-year-old woman. She comes in with severe hospital-acquired pneumonia, ends up intubated, hypotensive, and needs vasopressors just to keep her blood pressure up. Her body is in profound shock. The absolutely critical question is, when and how do you start feeding her? Well, here is the definitive evidence-based answer. You start enteral nutrition, or EN, feeding through the GI tract as soon as her shock is controlled and her vasopressor needs are stabilizing. There is absolutely zero role for early parenteral nutrition, or PN, which is feeding directly into the veins. The data on this is incredibly clear. Which brings us to Section 2, Rule 1, use the gut. Why do clinical guidelines favor the gastrointestinal tract so heavily? You see, the gut isn't just some passive pipe. It's got complex digestive, immune, and hormonal jobs. When you starve the gut, the normal healthy bacteria morph into a harmful pathobiome. The gut wall gets leaky, toxins escape, and suddenly you're driving multi-organ failure. Enteral nutrition keeps that mucosa alive and actively dampens inflammation. On the flip side, parenteral nutrition, or PN, has historically been linked to way more infections and higher mortality, especially in our sickest patients. The infection risk with PN is dose-dependent. That is exactly why every major medical society prefers you use the gut. And this brilliantly illustrates that timing is literally everything. If the gut works and the patient is hemodynamically stable, you want to start EN within 24 to 48 hours. That early start actually lowers mortality and pneumonia risk. But, and this is a huge but, if the patient is in uncontrolled shock with rising vasopressor needs, the Nutria 2 trial tells us we absolutely must delay EN until they are fully resuscitated. Pushing food into a gut that doesn't have adequate blood flow, that is a fast track to bowel ischemia. Moving on to Section 3, calories and protein, and the new rule, go slow. Prepare to unlearn a lot of what you thought you knew here. We know where to put the food, but how much do we actually give? The calorie target has come drastically down. Today, we practice hypocaloric early feeding. Why? Because a critically ill body produces its own endogenous energy. It's like a furnace burning from the inside, and you simply cannot switch that off. If you dump full external calories on top of that, you're just overfeeding. That leads to hyperglycemia, more infections, and a fatty liver. The Nutrirea 3 trial proved that low calories, we're talking just 6 kilocalories per kilogram, resulted in faster recovery and fewer GI complications compared to standard feeding, and get this, with 0 extra deaths. What does that number mean? That right there is the increased relative risk of 60-day mortality if you aggressively feed protein to ICU patients who also have acute kidney injury. Let that sink in for a second. Aggressive protein was actively increasing the risk of death in these highly vulnerable patients. This stunning realization came from the EFFORT protein trial. The old dogma told us to push up to 2 grams of protein per kilogram to fight off muscle wasting. But EFFORT showed us that high protein offered absolutely no survival benefit. It didn't stop muscle loss, and it actively harmed patients with AKI or high organ failure. The updated practical target is much lower, around 1.3 grams per kilogram. And crucially, you have to introduce it gradually. You cannot front-load protein in those first few critical days.
Section 4, Autophagy, the body's recycler. To truly grasp these new guidelines, we have to look at the underlying biology.
It all comes down to a microscopic process called autophagy, which literally translates to self-eating. Think of autophagy as the body's built-in recycling and quality control system. It clears out damaged cellular machinery and toxic protein clumps and recycles them so the cell can survive. It is absolutely essential for immune function and preserving muscle quality during critical illness.
Now here is the real kicker. Autophagy is switched on by starvation and oxidative stress, but it is switched off by overfeeding. The PPAC trial proved that early administration of amino acids, protein, actively suppresses autophagy. So when you aggressively push protein on day 1, you are literally shutting down the body's primary recycling system. The result? Weaker muscles and a much slower recovery for your patient. That is the biological why behind why we need to go slow.
Section 5, Refeeding Syndrome and Risks. We understand the biology now, but we have to talk about the practical, real-world dangers when you do finally start ramping up that nutrition. Now, what's really interesting here is the current 2023 to 2025 clinical protocol for managing refeeding syndrome. When you restart feeding in a patient who has been starving or is highly stressed, their insulin spikes. That spike drives phosphate rapidly into their cells, which can trigger sudden, fatal cardiac or respiratory failure. You've got to watch their lab values like a hawk, specifically looking for sudden drops in phosphate, potassium, and magnesium. The actionable steps here are super clear. Screen your high-risk patients. Give them 100 milligrams of thiamine before you introduce any feeding or dextrose. And if you see their phosphate drop by more than 0.16 millimoles per liter within 72 hours of starting feeds, you must react immediately. Cut their calories way down to 25% of the target for a couple of days. This strict caloric restriction has actually been proven to lower long-term mortality in these high-risk patients.
Finally, Section 6, the new feeding mantra. We've thrown a lot of dense, life-saving trial data at you today. Let's distill the whole shebang into a couple of practical, memorable mnemonics.
First up, when you delay enteral nutrition, use the visual anchor shock bag. You hold feeds for uncontrolled shock, obstruction, abdominal compartment syndrome, severe kidney injury or acidosis, GI bleeding, abdominal ischemia, or gaps in perfusion. If your patient is dealing with these, hit the brakes on feeding. On the flip side, what should you completely ignore? Remember, GROB. Do not stop enteral feeding just because of high gastric residuals or sluggish bowel sounds. These metrics are subjective and notoriously unreliable. GI intolerance is used way too often as a bad excuse to underfeed someone. Checking gastric residual volumes doesn't even prevent ventilator-associated pneumonia because that pneumonia comes from oral secretions, not stomach contents. Keep the feeds going. So the crucial point is this. It's the overarching mental model that ties all these recent major trials together. Nutria-3, Pepanik, and effort. Start low, go slow, do not front-load protein. For days 1 to 3, embrace permissive underfeeding, give modest protein. Step back and let the body's endogenous energy and autophagy work their magic. Only after day 3 should you slowly start titrating up toward their measured needs. Today, we've seen just how drastically the science has shifted. The completely intuitive idea to immediately feed a starving, sick patient actually turned out to be biologically harmful because it got in the way of the body's own survival mechanisms. Which leaves us with a pretty provocative thought to wrap up on. If feed early, feed hard was taught universally for decades and turned out to be entirely wrong, what other deeply ingrained medical dogmas are just waiting to be overturned by the next wave of clinical data? Always question the assumptions and always follow the evidence. Thanks for joining us for this Explain and Describe Learning Explainer. See you next time.